The research that we do is trying to improve oral health during cancer care. If you look at most recommendations that if you have head and neck cancer, your doctor might say, oh, you need to go to a pre-dental care, that's the standard of care. And I'm moving to during cancer care because I think patients, they need prior, during, and after. So the support needs to be more comprehensive. The way we started is that as a periodontist, I was seeing patients, radiation oncology. I referred to me as a dentist, and I just started looking at the patient's mouth, and then I decided to say, well, we need more cleanings and more frequent. So all the patients that I received in my office, I decided myself to do this very intensive treatment where the patients would come every week and I would do a very comprehensive prophylaxis in their mouth. After I treated like a few patients, maybe 15 at that time, I got a call from one of the radiation oncologists, which is today is my collaborator, and he was saying, Pat, can you tell me what you're doing with my patients? And I was like scared because I thought I was doing something wrong because it wasn't standard of care. And then he said, well, all the patients that we treated, they behave in a different way. They're not losing weight. The mucositis, which is a disease that I'm going to talk about it, they don't have the severe form, and the nutrition is much better, and they're not complaining of pain. So I just want to know what you're doing. And I just said, well, we're just brushing their teeth. So that's the difference that I'm doing. So that's what I'm going to talk a little bit here. It has to do with the oral microbiome as well. I'm a microbigeneticist, so I have the same line of research that the previous talk. So it will be a mix of clinical and the oral microbiome. So as we know, in head and neck radiation therapy, 3% of all cancers, they are head and neck. It's approximately 300,000 deaths a year. It affects numerous anatomic subsites, and every patient with head and neck cancer, any stage, it will be recommended radiation. There are few recommendations from the American Academy of Oral Medicine for dental evaluations. They're very concerned, and they say that it should be done before head and neck RT, and independent of patients if they're receiving RT or combined treatment. Some patients will have RT plus chemotherapy, others don't need that, depending on the staging, and they will be at risk for caries, periodontal disease, and osteonecrosis, which is the more severe side effect. And the oral care is recommended because reduce the risks of infections during treatment, and especially the risks of oral mucositis and osteonecrosis, which is an infection on the bone due to the radiation. And this should be done, completed at least 2 weeks before the RT, and the dental team needs to be coordinating all those visits with the oncologists. So what are the issues? So we all know that the oral and dental care is very important for prevention and intervention if we need it as well, and should be done before, during, and following cancer care. The more acute complications are the mucositis, which I'm going to describe later. It's issues with saliva. Patients report that difference on the quantity, the saliva becomes like quality as well, becomes like thickness of your saliva, and it's very uncomfortable. There are taste differences, changes, a lot of pain, infection. More chronic complications would be, again, the mucositis, also saliva. They can be like for a long time, even after radiation is done, because the radiation might damage your salivary glands. You have taste, infection, osteonecrosis. There are a lot of rehabilitation issues. Function affect function because people might have concerns about talking and caries, again, periodontal disease. And what is the impact of intervening like that? Well, reduce cost of care. You prevent hospitalization on those patients. It helps with diet, nutrition. If you don't have oral ulcers in your mouth, of course, you're going to eat better and you're going to go through your cancer treatment much better. And of course, infection and will prevent some pain as well. So this is the classic oral mucositis, which is the patients after, on the second week, you develop a lot of ulcers in your mouth. They're very painful. It's due to the toxicity and a lot of changes that are going on during the treatment. And it can be either if you have radiation, but chemotherapy can cause that too. So what are the current treatment? It's all palliative. There is not any effective treatment for this disease that we call oral mucositis. So it's mostly they will ask you to rinse with different solutions. There are topical gels, oral anesthetics. They need to have a lot of pain medication, and it takes time. They just say you need to go through, and it's going to take time. When you finish your treatment, you're going to recover slowly. There is one medication that is on the market for oral mucositis, but it's not for head and neck cancer. It's a very specific of bone marrow transplant patients, which is FDA regulated. It's like IV. And there are other treatments that we starting to implement at the Cancer Center. I'm going to give a very brief flavor of that. I told Rachel today that we should do another seminar to talk about the low light laser, which is this novel treatment that we bring into the Cancer Center, but we don't have time today. And some recommended cryotherapy as well, which is cold ice chips during radiation, because prevents some of the changes on the oral cavity prevents oral mucositis as well. So we did some research with the nurses at the Cancer Center, and my student, which is a postdoc student who is here today, we started with a retrospective chart review. We want to know within the Cancer Center how many patients developed mucositis, how many didn't, and why they did that. So when we review 187 charts. We took hospital costs. We want to know how much those patients cost to the hospital based on severe mucositis, no mucositis, mild mucositis. It's impossible not to have mucositis. In head and neck cancer, almost 100% of those patients, they will develop some degree of oral mucositis. And all the analysis that we do, they're focused more on every toxicity that was related to oral mucositis. We excluded any other charge that were unrelated to that particular disease. So I'm going to go very briefly here, but when they select charge, they look at different angles and different ways, and they have, for example, they call variable direct costs, which is costs that are related to each patient itself. There are other costs that are related to nurses, and if the patient had to have IV and sedation, so there will be more hospital and related. So when we look at the differences between the patients that developed mild mucositis with severe mucositis, we clearly could see that the patients with that severe mucositis, they spend much more money. The hospital spend more money with them because, of course, they got more disease, hospitalization, and they need other type of care. And if we look what were the procedures that predicted an increase in treatment costs due to the severity of the disease, there were people who had more moderate and severe, of course, a form of the disease. The ones that had combined treatment, they received radiation plus chemotherapy, so they had more toxicity in their body. And then also other things that we saw was feeding tube, because if you have those ulcers in your mouth, you can't eat, you cannot drink, and it's so painful that they need to put a feeding tube so you can have the proper nutrition. Other things were hospitalization. Those patients, because they got dehydrated, they couldn't eat, they need to be hospitalized. And things like medication, painkiller, narcotics, and painkiller opioids were like one of the things that trigger, because they had so much pain and the doctors needed to prescribe more medication. And so this is I'm going to just move away a little bit and talk about the oral care protocol that we developed. It's not a standard of care. That's why we're doing research right now. So if you go to a regular dentist, they would not provide this type of protocol. We did a small pilot, and we're about to start a new grant where we're going to enroll more patients on that, but we need to do under research. So the idea and the research behind this protocol is that our objective is that we want to test this protocol to see if they can prevent oral mucositis severity, which is what we did with our pilot. And other objectives, I wanted to look at the microbiome. What are the shifts on the oral microbiome? What are the difference between the patients that I treated versus the patients that we didn't brush their teeth? And other things that we look as well is the immune system. So we collect saliva from those patients, and we look for a few of cytokines that trigger inflammation in your body when you have something going on like that. So, well, the hypothesis was very simple. We believe that a target regime of oral hygiene during cancer care, not only before or when you finish, the most important time is during cancer care, prevents ecological shifts of the oral microbiome, so you preserve the ecological, the good bacteria in your mouth, and you don't let the bad bacteria suppress that. And we reduce the severity of the disease. As again, it's impossible to prevent that people will not have mucositis, but we can control really well that it's not going to get on the severe way. We prevented oral mucositis pain, inflammation, and of course, if you do all of that and you have a better quality of life, we can improve quality of life during cancer care. So again, what we did, we treated the patients across the whole radiation cycle. We enrolled them when they came for the first visit to do the planning for the RT. We watched them as the nurses would come and look at their mouth every day, and the moment they saw one of the oral mucositis lesions on their mouth, they would send us to the dentist so we could start the procedure. And the study would be like up to 6 or 7 months, depending on the radiation cycle of each patient. And we saw them like 3 months later as well to collect more samples. That was a very small pilot. So what was the treatment? So the control group was actually not a placebo group. We did a standard of care. We made dental hygienists and dental professionals just brush the patient's teeth, and we taught them how to do a proper oral hygiene throughout the oral cancer treatment. And then for the cancer treatment, in head and neck cancer, not only oral cancer. We gave them toothbrushes, toothpaste, oral rinses, and they all need to use our products. We didn't let them use anything else outside the study. For the intervention group, which is the protocol that we do, on top of doing the oral hygiene, we did a professional cleaning. I don't know if you probably did that in the dentist already, where we have a machine that is an ultrasound machine, and we do with comprehensive dental prophylaxis. It's like removing calculus and plaque and every type of abnormal plaque in your mouth. And on top of that, we clean the oral mucosa, which I think was the key for the protocol. We had a very soft brush, and on top of cleaning their teeth, their gums, we also cleaned the whole and irrigated the whole oral mucosa and the tongue, the cheeks, every surface of the mouth. And this was done every week. We gave the kit to the patients as well, and we taught them how to do that at home. So they did once a week with the professional, and then at home they would continue with that regime. So now I'm going to show a little bit of the data. We did some preliminary analysis on oral microbiome, and the first time point that we look is that when they got enrolled in the study and they have no treatment at all, on the point that we saw the first ulcers in their mouth. Because I wanted to know if there are any changes, any shift on the oral microbiome at that point due to the radiation and due to the cancer treatment. So technically, is the image on the left is the visit 1, and this is visit 2 would happen any time between around second week of radiation. Of course, patients who were more compromised, it might be before that, but it's between the second and third week of radiation that we see the signs of oral mucositis. So again, our sample size was very small. We had 15 patients on this pilot because we're submitting to a large grant. And there we had cancers of the oral cavity, and other cancers were oropharyngeal and nasopharyngeal. So the first thing that we did on the microbiome, we look was that we could clearly see the differences, patients between before the onset of the disease was a completely change of the oral microbiome that could even separate on that. We look for over 600 different bacteria on this sample, and we collected swabs. We had like a little brush, and we collected several swabs throughout the whole mouth, because we want to know if different sites had colonization by different bacteria. So on this very preliminary analysis, we saw that one bacteria was it was the top bacteria associated with the onset of the disease and the Gamella hemolysions. And if you look on the literature, this bacteria it's a gram-positive, but it's associated with other type of infections in hospitals as well, which is endocarditis, meningitis, some people with post-surgical complications, septic shocks, bone infection, and others. So that's very preliminary data, but the idea is that what I want to do is to create, how can we profile a patient before they go to cancer care? And if you can predict the patients that they're going to perform well or not based on their profile, they will be very important, because then you can intensify care and what the needs that patient will need compared to the others. If you can have a biomarker that show that, oh, this patient will not do well. And what we found that with this bacteria is that even the patients who got into my protocol on the oral care was very resistant. We couldn't get rid of it. Throughout the whole cancer center, 3 months after, the patients still had this bacteria. We also look at fungal infection, and fungal infection was also highly associated with the onset of the disease, and which one more reason why you need to have a very proper oral care, because fungal accumulates in your mouth due to reduced saliva and sometimes immune system. If your immune system go down and if you don't brush well, that's when you have that. Sometimes stress, and during cancer care you have all of that going on. And there was other things that were associated with fungal infection as well, like saliva flow. They got reduced on patients who had a lot of fungal infection in their mouth. They reported sticky saliva and trouble with eating and a lot of pain. So I'm going to show a little bit of the longitudinal data. I'm not showing the microbiome longitudinally because it's a very small sample size. So to do microbiome, you need a large population so you can have very sensitive biomarkers. So I'm going to focus on the immune system, the immune response of those patients. So when we collected saliva from those patients' mouth in the morning, every week when they came to the visits, and we compare about 10 pro-inflammatory markers on this experiment, and what we show, to me, is the most important data out of the study, is that the patients who brushed their teeth, they received the oral care, they had all of them completely reduced. They went to the negative, actually. And all the patients who did not get the protocol, they had all those, which is the control, the black bars that you see, they're all increased. They didn't even preserve the same way, they got increased because of the lack of oral care. So we look at other clinical outcomes as well on those patients. The data is not significant, again, in terms of scientific, the way we look, because it's a small sample size. But if you look at the control compared to we call OMDP, which is the treatment group, the patients who did not receive the oral care treatment, they lost more weight because they couldn't eat. They got more severe oral mucositis. They reported a lot of pain compared to the other group. There is a scale that we look for emotional function, how depressed and how they're feeling, and they reported much more depression, anxiety, and other issues on that. They had more difficult swallowing, probably because of candida and all the ulcers in their mouth. And they had also more reduced salivary flow, so compared to the other group. So we took, this is a small screenshot from the chart review that we did. So what I did, I said, how about if I compare the patients that I treated on my protocol against all the other patients that were not treated, not even on my protocol, but on that year that went to the regular cancer. I'm sorry? Implants, this is medical implants. If they need to do a feeding tube, it's not related to dental implant. So the data was very similar when we compared my small group of patients against the other one. The patients that were not on my pilot, they also spent more money with the hospital because they required surgical supplies, because probably they got hospitalized and they needed more care. They spend more on the pharmacy, and I'm assuming more opioids use. They had to take more radiographs. So everything was more expensive for those patients when we compared that small subgroup as well. So this is the new study that we're going to do. We're going to start at the cancer center, where we want to have all patients who are receiving radiation for head and neck cancer to go through this specific protocol. Hopefully we're going to start soon, but it's almost very similar with the previous pilot. The only difference that I did on this new, because we learned that the oral care needs to be preventive, so I'm not going to wait until they develop the oral mucositis. So the moment they're going to start the radiation, we're going to do the oral care intervention, because it's beneficial for the patient to have as early as we can give them. So this is the new dental operatory that we just implemented at the cancer center, because the chair of the radiation oncology is very supportive of this interdisciplinary approach. In this dental operatory, we're going to start different programs, all target for oral care during head and neck cancer. And that would be for prior to for the cancer care. It could be during cancer care, but we want to do for after they finish as well, because most patients, when they go through head and neck cancer and they receive RT, they have a lot of late side effect we call chronic, which could be anything for persistent oral mucositis, dermatitis, fibrosis, and lymphedema. There are many issues that can persist, and all dental issues as well. They might need care. So we're very eager to provide that type of care to our patients. So NYU has started a whole new vision about oral care, which I'm very happy as a dentist. It's very hard to convey to doctors that they need to look at patient's mouth every time that someone goes to them. So just recent, NYU was on the New York Times probably a month ago, where they started this new program to prevent hospital infection when you're in the hospital. And then every patient today that go to surgery, they would give you like a kit, which is a dental oral mouth rinse, and they make patients within like 2 hours before they go in surgery to brush their teeth, tongue and their teeth. And they're showing that this is preventing a lot of hospitalization infection within their population. Another group that I just became part of as well, that was ongoing before I came and I started my program, is the Mucositis Oversight Committee. And we've been constantly meeting and trying to create specific protocols so people can be aware. And all the nurses, they need to look at patients' mouth, and they need to all be aligned on the type of care and the type of recommendations that we need to give to those patients. This is the new area that we're going to implement next month at the Cancer Center as well, which is low light laser therapy. Light has been shown to be extremely helpful for different conditions and diseases, which is more a healing mechanism, and it can be very effective to treat oral mucositis because it's good for pain, and we don't know yet if it does anything with the oral microbiome. I believe it does. It changed a little bit, and we just received our instruments at the Cancer Center, and we're planning to offer to patients. And this is a very efficient treatment as well for late side effects, as I mentioned before, dry mouth, dermatitis, lymphedema, and issues that you have that I finished my cancer treatment and we could use this type of treatment. This is the team. As I said, it's a multidisciplinary approach. We're working together with this dental school within NYU. We have oncologists, we have dentists, nutritionists, and all the team from the palliative care group that we all working together on this effort.